Good evening, and thanks for joining us tonight. We're doing a healthy lifestyle talk tonight, which is just an opportunity for us here at Northern Inyo to showcase our workforce and some of the services that we offer to the community, and also gives us an opportunity to educate our community on some of the services that we offer and why we think they're important to us. So tonight we'll be talking about infusion therapy close to home. And I've got 4 experts here to help us talk about the services that we provide here at Northern Inyo and why we do it and why we think it's important. So I'd like to just introduce our panelists tonight. Tammy Andersen. She's in the middle of that square there that says Tammy Andersen. She's the manager of our peri-op area, and the peri-op area encompasses more than just the outpatient infusion center, but it does include the outpatient infusion center. Tammy grew up here in the Mammoth Bishop area. She got her nursing degree at the Orvis School of Nursing at the University of Nevada, Reno. And she has been in this role for about 2 years, and previous to that, worked as an RN in the department. We also have Rosie Graves. And wave, Rosie. Rosie is our oncology patient navigator, who has a really close relationship with a lot of the patients who receive services at the outpatient infusion center. Rosie's been with us here at Northern Inyo for more than 12 years, and prior to that, she was the administrator at Sterling Heights. She got her degree from her bachelor's and master's degree. It doesn't say what school. Where did you go to? What school was that, Rosie?
So my undergrad degree was in healthcare management with Ottawa University, and I obtained my master's in public administration with Grand Canyon University.
Awesome. Also in that little square with the rest of them is Christy McIntire. She has been in this area for 24 years. Also went to the same school as Tammy, the Orvis School of Nursing at the University of Nevada, Reno. Been with Northern Inyo for 14 years. Currently working as a PACU RN, which again also includes the outpatient infusion center. And lastly, but not least, is Dr. Wakamiya. She's joining us. She is a specialist in internal medicine and geriatric medicine. Dr. Wakamiya did her undergrad at Princeton University, got her medical degree at UCSF, did her internal medicine residency at UC Davis, and then her geriatric fellowship at UCLA. So I want to welcome all of our panelists and really thank you for taking the time to share your knowledge and your expertise with us. And I guess I'm just going to start with you, Tammy, being the manager of the peri-op area. Can you just kind of tell us what is, I mean, the title of this is Infusion Therapy Close to Home. What is infusion? What does that mean?
Infusion can mean anything. I mean, anything that you get given to you IV or an injection of some sort for a disease process you might have. Something we give all kinds of infusional things, from antibiotics that you might need daily for 42 days, let's say, and we place a PICC line and you get that, and then you don't have to go anywhere. Yeah, so infusions can be anything. They can be for all kinds of disease processes, like osteoporosis. We might give an injection of Prolia, let's say, or reclass infusion. You might have multiple sclerosis, and you might get an infusion for that, Ocrevus, and then rheumatoid arthritis or any other disease process like that. We give numerous things for that as well. We're giving new medications for migraines. We're helping with the MAT program, infusional wise. That's the opioid disorder. We give injections for that, and they don't have to take those orally anymore. We give anything like blood transfusions, hydration, chemotherapy, and injections with that as well. Lots of iron infusions lately, lots of them, helping the community. We work with our partners out of the area, like City of Hope, Carson Tahoe, Cancer Care Specialists in Reno. They help with infusions here. You might go see them and then see your primary, maybe like Dr. Wakamiya, and then she would help us facilitate that.
So let me interrupt you there for a minute and pass it to Dr. Wakamiya. So
Perfect.
in what instance or why would you prescribe an infusion for a patient versus just a pill?
That's a great question. And you would think a pill would be a lot easier to take because you can take it at home, you can get it from the pharmacy, and an outpatient infusion often requires the placement of an IV, of a needle into the vein or a catheter, an injection of the medications. It's a little bit more involved. There's a nurse there who's monitoring you during the infusion of medication. So you may have your vital signs monitored, and you may have other blood work that's drawn at the same time. So it is a much more involved process. However, in a lot of the cases that Tammy mentioned, there's some real advantages to having medications given either intravenously through the vein or as an injection into the subcutaneous tissues. And the advantages, one, some medications just aren't absorbed well orally, and that could be due to the medication or also due to the particular person and to their gut. And for example, iron is a really commonly prescribed medication for iron supplementation in the case of iron deficiency anemia. And iron can be can cause a lot of GI or gastrointestinal side effects like constipation and irritation, and also might not be absorbed equally by everybody. So sometimes intravenous iron can be a much more effective way of repleting iron rather than taking a pill. It's also much faster. And so several doses of iron over the course of 1 to 2 weeks may result in better repletion than taking iron for 6 months or so. And so in that case, it has clear advantages. And I can speak to a couple other scenarios in which there are advantages. So
well, let me stop you there.
Pass the torch.
Yeah. Okay, so for example, let's say I go and see you as a patient and you say, oh, you need iron and it's not well absorbed through my stomach. And so I would benefit from having it given to me through the IV. So how do I know if my insurance covers that? Or how do I know that I can go to Northern Inyo and have that given? I don't know if Tammy or Rosie have any insight into how that works.
Well, I think it's really important from the intake perspective, and that's part of my job in the role and with Christy Almeida in there, who's been there for a couple of decades, where we will streamline that process for a patient, another medical organization, or the primary care doctors, and saying, hey, can we do this here? And then one of our first steps is, yes, the authorization and making sure we can do it. But before that, we need to make sure we can get the medication. So if the medication is available to obtain through our pharmacy, then that's the green light where we can go and get orders, we can get the clinical documentation and then the authorization. And if authorization can be somewhat of a financial stressor on some patients, where if there is a patient assistance program, that's where, again, where our navigation is a real key in guiding them to that type of resource and working with the doctors and providing the necessary documentation to get them to come here.
Okay. And so, Dr. Wakamiya, what are some other typical medications that you would prescribe that you feel like that there is an advantage to be given through the IV?
That's a great question. I think in addition to IV iron, there's 2 other classes that come to mind, or well, a couple more, but two that I prescribe, and then 2 other classes that I really collaborate with specialists on. The 2 that I commonly prescribe are medications for osteoporosis and also antibiotics. The medications, so taking a step back, osteoporosis is a condition where the skeleton becomes more fragile, where the bones lose mass, and ultimately puts a person at higher risk for fracture in the case of a fall or minor trauma. And this condition can be treated with oral medications. However, the oral medications are sometimes not well tolerated and again can cause gastrointestinal symptoms such as reflux. And there's also some newer medications that are now available, and those are injectable. So the combination of the older medication in intravenous form and the newer medications that are injectable, I would say those are the most common that I prescribe. And those are usually dosed once yearly or once every 6 months. And those are nice because there's monitoring during the injections, and you can, and the outpatient infusion center, you can also get a medication before the infusion to prevent side effects of the infusion as well. For example, Tylenol, or if there's a reaction potentially expected at Benadryl or nausea, there's other medications. So that makes the process easier as well. So osteoporosis is one class, and then a second class is antibiotics. And I think the question is, well, antibiotics is another one of those that you could just take a pill for, and it's easy, just go to the pharmacy, don't really need an IV for. But there are some cases when there's infections that are caused by bacteria that are resistant to common oral antibiotics. And in that case, it's really important that we have access to intravenous antibiotics. And depending on the type of infection, it might be a short course of antibiotics, 5 to 10 days, or for an infection, for example, the valve of the heart, those require a longer course of antibiotics, as Tammy was mentioning, even up to 6 to 8 weeks of antibiotics. And so having access to the intravenous antibiotics is also really important.
Okay.
And then I also work with specialists. So there's a couple of classes of specialist medications that I think come up regularly. One is the chemotherapies for cancers, and there's chemotherapy, and we're also administering immunotherapy here, which is huge. So you can get the latest cancer treatments right here at NIH, which is really exciting, and it just allows people to be closer to home, comfortable in their own home while they're getting treatment. We can even set people up for an infusion where they can go home with an infusion. So some infusions take 24 hours, and we can do that here. So that's really exciting. And I think that's been wonderful to have for people in our community. And those orders can be directly from your oncologist. So an oncologist in California can prescribe those medications here, and that's it. You can receive treatment here. I think, as I just learned, that out-of-state providers, that the primary care provider, like someone like myself, would sign off on an order for a chemotherapy if the order is coming from out of state. But it's still a relatively straightforward process, and we can do a lot of care here. The other types of medications commonly that I work with specialists on are rheumatologists, and medications for rheumatologic conditions and inflammatory conditions such as rheumatoid arthritis, inflammatory bowel disease. That's actually more gastroenterology, but psoriasis, psoriatic arthritis, these conditions, there's a lot of agents that are injectable. They're biologic agents. And those we can give those here, right here at NIH. And so even if your specialist is not in town, you don't have to go to receive those medications out of town. You can get them here in Bishop. And that's some nephrologists as well will prescribe IV iron, and we help facilitate that. So it's really wonderful. We can do such a wide range of treatments here with these medications.
Yeah, because as we all know, we really have a lack of specialists here in town. But we're lucky enough to have someone like Rosie, who is an oncology patient navigator. And so obviously, as you mentioned, Dr. Wakamiya, like partnering with all of these different specialists, but I think there is a special focus on chemotherapy, just because, as we all know, chemotherapy tends to make you not feel so good. So it really is a wonderful convenience to be able to receive it close to home. So Rosie, I don't know if you kind of want to talk a little bit specifically about your partnerships with other oncologists in California, outside of California, what your role is as a navigator, and how that relates to the infusion center.
Well, I think the most important piece is being able to navigate these oncology patients immediately and informing them up front of what's going to happen in the process. And, we don't have medical oncologists here locally. So they're going to go north, east, south, and west. And I navigate, and our doctors will navigate to patients where they have the most support with family. So if you have someone who lives in Sacramento, we're going to go that direction and such. So we're pretty fortunate. Most of our patients will go south. A big chunk of them will go down to City of Hope, where we can partner with the Antelope Valley location and the Duarte location. And we also go north, but again, it really depends on insurance and which way they're going to direct us to. So, but my role is really to direct them, let them know I'm there for them, direct them to local and national resources, locally, we have the Eastern Sierra Cancer Alliance that really can help take a lot of financial and emotional burdens off of them. But that's a big piece also of bringing them back home. And I let them know up front, it's really common for the medical oncologists who want to maybe try the first couple cycles of treatment at that location, just to monitor them, make sure that's going to really work with them. And as soon as they feel comfortable, they're going to bring them, we're able to bring them back home. And we've established a great relationship with a lot of these medical organizations. City of Hope is huge. We have a big pull from them where Tammy is on the phone constantly, working with that and streamlining orders and such so that we can get patients home. And so that's how I do it. I let them know up front the process, and it might take 1 or 2 cycles down there, but eventually we can probably, we never say never, we never say always, but we can probably get them back home. So, and if we can do that, that's success for us.
And so I would say that, a lot of people, it's a little unnerving potentially to have your specialist away from where you're receiving your medications, but it's nice to know that there's that partnership and that route of communication. Tammy, can you talk about like the experience that we have here? How long have we been doing this? How long is the Northern Inyo had an outpatient infusion center? And maybe Ann Wagner could help us with some of the history as well.
What did she say? A couple decades, right? She started the whole thing. I believe that's correct. Way back in the day. Is that right, Ann?
That is. We started, I think it's been 25, 30 years ago. One of our employees needed to have chemo, and that kind of prompted us to look into getting certified for oncology treatment at NIH. And then we developed it around the patients that were coming in, and we got training brought in, and we really ramped it up, and we got it really well put together in a year.
I thought so. Thanks for starting that. Yeah, so from
You're
there,
welcome. It's the thing that I felt the proudest of in my 40 years at NIH. It wasn't something I intended to do, but it fit with what we were doing with outpatient services, and the community needed it. And I was so happy that we could get it going. And I'm so happy for the medical support we have, both at NIH and the oncologists outside of NIH who really got it put together for us with trusting us to give these drugs. So
yeah, thanks, Ann. Yeah, it's true. We are all, there are 7 or 8 of us that are permanent staff members, and everybody is certified oncology nurses from ONS. So every 2 years we re-up. We do quite a few chemos on a weekly basis, and we partner with City of Hope and, like Rosie said, and Carson Tahoe and the cancer care specialist in Reno as well, so in Nevada. And we do the home therapy, like Dr. Wakamiya was saying, with one of the chemos. We have a couple patients doing that with some lovely home pumps that they rent at City of Hope. They come with them, and then we have the supplies to keep it going, and our pharmacists go mix the medicine. Christy is one of my nurses that would be, she's my CSE and one of our oncology nurses, and maybe you could talk about how the infusion goes a little bit.
Yes, we can start where once Rosie gets you on the schedule and gets you to come into the hospital, then I'll come and grab you, bring you back, put you in a nice little cozy bay that's all to yourself, where some infusion centers, when you go to down there, you might be stacked up next to 10 or 20 people. And here you get to get your own little spot, and you can have a support person if you need it. And then we'll get your vitals and start an IV, or if you have a port, we'll access that. And then we start you on all your pre-meds that Dr. Wakamiya was talking about. And then you get started on the chemo or the biotherapy or whichever infusion that you're getting. And then once that's finished, we tend to any other needs, get your vitals, and then get you out the door, and then you get to go home.
Instead of driving really far to come back. Or
Having to drive 6 hours to get home.
Yeah, very nice. They're very good at it. Yeah, we have really great success here with our chemotherapy services.
Wonderful. We did have a question come in, and maybe Rosie or Tammy can talk to this. Do clients on Medicare and Medi-Cal qualify to receive these medications and services?
Yeah, so Medicare is one that, we don't need to get pre-authorization on. And depending if they have a secondary with Medicare, Medicare usually covers 80%, and then the residuals would go to your co-insurance. If you have Medicaid, same thing, it would be the Medicare, Medicaid, and it would be the 80-20 scenario also. If someone's got straight Medicaid, we go through the authorization process, and that has to come from the medical oncologist's office to get the authorization. So that is, again, something we would do on the intake, the onboarding of bringing a patient in and going through all the approvals. If there's any hiccups, like I said before, with insurance covering something, that's where we can reach out to different patient assistance programs with the drug companies themselves, because there are numerous programs out there that will cover the medications. We actually have a handful plus of patients that the medication is actually brought in from Ocrevus is one of them, and such, where the medication comes directly from that patient assistance program. So we work with it. I recommend to anyone, whenever in doubt, just ask, and it doesn't hurt to go through the process. We've had great success. And if let's, for example, a medication isn't covered, there might be a biosimilar or an alternate medication that they would work with, and that's where, again, that specialist is gonna, they know what's out there, and they will research it and find out what we can do.
And now, Christy, back to you. I think Tammy mentioned that you were something called a CSE. So can you talk about what that is and how it helps the rest of the staffing? Because we all know that there's nursing shortages. And so, how have you guys dealt with that, kind of on the front line, so to speak? And then what's your role as a CSE? What does that mean?
The CSE is the clinical staff nurse educator. So anybody that comes to our department that doesn't have their chemo cert, we help get them educated with that, or any other medications or infusions, injections, whatnot. I do all the education to that with that nurse prior to them ever giving the medication, just to make sure everybody's up on all their education and understands how it works and any complications that could happen. And then sometimes we ride along with that nurse, and then eventually everybody can do it on their own, and once they are confident in doing it safely. And then, let's see, what was the rest of the question? That was the question. That's pretty much it. Yeah, I just make sure everybody's like up on all the different skills that they might need for any of the type of infusions that we're going to be doing.
Yeah, and I guess I imagine that that's been pretty challenging with just the number of traveling nurses and folks who maybe aren't used to doing this kind of work.
Yeah, there's or you'll get somebody trained and then somebody leaves, and then it's kind of a constant battle of always retraining people.
Yeah, but it's nice to know that there's an expert like you who is going to make sure that everyone is, very competent before, they're any kind of
or even if I show them, they're always coming to me to double check on just the little nuances of things. And it kind of helps because I've been here the longest in the department, so after a while it's just oh yeah, we do this. We go this way.
Wonderful. Well, does anybody else in the audience listening on either YouTube or what else are we on Zoom? Have any other questions for our panelists? Or anything else that our panelists would like to add?
I want to add, or actually ask, kind of, I know COVID treatment has been a large part of outpatient infusion as well, and we haven't really talked about that, but I was kind of wondering what's the state of things right now?
Well, I know we're not doing the monoclonal antibodies at the moment. The oral actually is the suggested. Isn't that correct, Dr. Inglade?
Yeah. So the most recent monoclonal, bebtelovimab, is no longer effective against the most commonly circulating COVID variant right now. So the recommendation, the first line is Paxlovid, which is an oral medication. Second line is remdesivir, which is IV. and is a series of 3 injections. And, you know, we're touting all of the services that we offer, but we all know that we're still, at the end of the day, a small 25-bed critical access hospital that has some limited staffing. So that hasn't really been a very often a viable option. One, it has a COVID patient who's not feeling well, needing to come back into the hospital for 3 days in a row to get the infusion. So it's not something that we've really utilized. But certainly, and I don't know, Tammy, if you want to talk about when we did have all of the IV monoclonals, we were doing multiple a day at the height of COVID, probably about a year ago, would you say?
Oh, yeah. It was a daily process and not every day, 7 days a week. The nurses in the unit here, you know, 1 or 2 of them would go up to a negative pressure room, escort the patient up so they didn't touch anything, take them into the room, take their vitals. They had to meet all the parameters to get the medication. They would put all their PPE on to protect themselves and the patient, give the infusion, monitor them closely, keep them for an hour afterwards, and then safely get them back to their car and they would go home. And we would do that sometimes for out a good half of the day or more, and on the weekends as well, really accommodating and helping the public. It helped a lot of people back when it was working for those variants.
And that's probably
Thank you guys for stepping up. Yeah.
And it's probably another thing to kind of point out, especially as Dr. Wakamiya mentioned, antibiotics, and sometimes you're on these antibiotics every day for 6 to 8 weeks. This includes the weekends, and we still accommodate patients and make sure that they're getting the antibiotics that they need on the weekends.
We certainly do. The nurses are great here.
Yeah, we appreciate it. I know I had a lot of patients who benefited from those services over the last couple of years with COVID.
Yeah, it's really nice that we could have that the community can come here to get all kinds of help every day of the week. So
well, we have kind of a specific question from Lana, and I don't know if anyone's going to know the answer to this tonight, but the Onpro Neulasta device, I think you guys are familiar with that. Yeah. What is the status? And I guess
so we just did our first one on a patient here, and it went well. So we
you want to talk about what that is briefly for everyone else who doesn't know?
So it's a little device. It's about this, probably that big or so, and it has, you stick it on the back of the arm. It's called a sub-Q injection, and the medication is put into the device. The device is attached to the patient. It kind of sticks to their arm right here, and then it has a little needle that pricks the skin and places a little tube. It's called a catheter under the subcutaneous tissue, and it releases after 24 hours, I believe. It starts to release slowly. About 45 minutes, it releases the medication into the body instead of them getting an injection, like a physical injection. And then they can take that off at home. That's the beauty of it. They don't have to come back into the hospital again to get that injection. They can be placed, and then it would be given at the same time that they would come in to get it if they had to physically. So it went really well. So we'll start doing that as for all of the people who need that medication.
Which medication is it?
Neulasta.
Oh, okay.
Yeah. Instead of the injection, yeah, it goes into the little device there and does it itself.
Wow.
Yeah. Cool.
Well, I failed to mention at the beginning of this that so part of what prompted this conversation was that yesterday, so January 25th, was IV Nurses Day. And so IV nurses means that the outpatient nurses. And so we're kind of celebrating and then wanted to just make sure that our community knew about all the services that we offered here at Northern Inyo, specifically in the outpatient infusion center, because IV Nurses Day was yesterday. So happy IV Nurses Day yesterday to you guys. If there's no other questions or any other comments, we can probably wrap up tonight. Oh, there's another comment. Wait.
If you don't mind me reading it, Dr. Ingboy.
Not at all.
It says, on behalf of Derek and myself, this would be Cindy. We are so grateful for the ability for Derek to have chemo infusions at Northern Inyo. The entire team is amazing. And we will see the entire team next week.
Thank you.
Well, Well, thank you. Thank you everyone for joining. If there's any follow-up questions, we can probably put my contact information, Tammy's contact information in the chat. Certainly, if you are one who is going to have an infusion done, you've kind of heard about the process now in terms of insurance approval. We know that that can be frustrating and take longer than any of us want. But feel free to reach out to any of us and we can help update you on the status and other things. So, well, thank you, Dr. Wakamiya, Rosie, Tammy, Christy, and everyone who joined. Have a great night. Thank you.
Thank you.
Thank
Good
you.
night.
Thank you. Bye.
Bye.